Welcome to A4 Medicine. My name is Rahul Srivastav. In this update, we are not asking whether tirzepatide is interesting or popular. We are asking what NICE is actually recommended for whom and why this matters in primary care. The central distinction is this: a medicine can be licensed, NICE approved, and still not be immediately available to every patient on the NHS because NICE defines clinical and cost effective use, while implementation has to be delivered safely and fairly across the service. Tirzepatide is a long-acting dual GIP and GLP-1 receptor agonist. In practical terms, that means it acts on the hormone pathways involved in appetite regulation, glucose handling, and energy balance with receptors found in the pancreas, gut, adipose tissue, and brain regions linked to food intake. That physiology matters because the drug is not just suppressing appetite in a simplistic way, it is modifying satiety signaling and metabolic regulation, which helps explain why NICE accepted it as an effective adjunct to diet and physical activity in obesity management. Think of tirzepatide as enhancing the body's post-meal hormonal signals so patients feel fuller, eat less, and improve metabolic control. The main NICE threshold is deliberately narrower than the medicine's broader license. NICE recommended tirzepatide for adults with an initial BMI of at least 35 and at least one weight related comorbidity, because this is the group in which the committee judged the balance of benefit and cost effectiveness to be acceptable for NHS use. So the question was not only does it work, but also in which population does it produce enough health gain to justify NHS funding. NICE eligibility is cost effectiveness threshold, not just a pharmacology threshold. The lower BMI threshold for some ethnic groups reflects differences in metabolic risks, not a difference in standard of care. NICE recognizes that people from South Asian, Chinese, other Asian, Middle Eastern, Black African, African Caribbean backgrounds may develop obesity related complications at lower BMI values. So the threshold is usually reduced by 2.5 kilogram per square meter. Physiologically, this reflects the reality that BMI does not capture metabolic risk equally well across all populations. So the same BMI does not always mean same metabolic risk. The comorbidities matter because NICE is targeting patients in whom excess adiposity is already translating into measurable disease burden. High blood pressure, dyslipidemia, obstructive sleep apnea, cardiovascular disease, and type 2 diabetes are markers that obesity is no longer just a risk factor in the background, it is now driving active pathology. That is why the guidance is built around risk stratification. Who is most likely to gain meaningful health benefit from effective weight reduction now? The comorbidity list is really a list of obesity already causing harm. Uh, NHS phased rollout queue. This is where many clinicians and patients understandably get confused. NICE recommendation does not automatically mean universal immediate access because NHS England has introduced tirzepatide in phases, while services build capacity for assessment, prescribing, titration, monitoring, and wraparound support. So at the moment, access is prioritized for those with the highest clinical need, and only over time will wider groups within the NICE recommendation become eligible. So NICE defines who should get it, rollout defines who can get it now. The 6 month checkpoint is there to keep treatment proportionate and clinically countable. NICE says that if less than 5% of initial body weight has been lost after 6 months on the highest tolerated dose, clinicians should decide whether continuing treatment is worthwhile, weighing likely benefit against ongoing burden and risk. That makes physiological sense as well. If the expected downstream effect on appetite intake and weight trajectory is not materializing despite adequate dosing, then indefinite continuation is harder to justify. In one line, if biology is not translating into meaningful weight loss by 6 months, the prescription needs rethinking. The practical pathway is straightforward. First, establish whether the patient meets the NICE clinical threshold, including ethnicity adjusted BMI where relevant. Second, check whether they fall into a rollout cohort that currently has NHS access. Third, if treatment begins, it must sit alongside reduced calorie diet and increased physical activity because tirzepatide was recommended as an adjunct, not a replacement for structured obesity management. So tirzepatide works with lifestyle support, not instead of it. The overall nice message is careful but important. Tirzepatide is a meaningful new treatment option, but it is not a blanket obesity treatment for everyone with raised BMI. NICE's committee recognized obesity as a chronic condition that affects physical function, mental well being, and long term risk of diabetes and cardiovascular disease, and concluded that there is significant unmet need. But the recommendation is intentionally targeted to the group where benefit, equity, and value to NHS align most clearly. This is target obesity medicine, not open ended cosmetic prescribing. For patients, the key message is that eligibility depends on both clinical criteria and the current stage of NHS rollout. For clinicians, the task is to assess BMI, comorbidity profile, ethnicity adjusted thresholds where relevant, and the patient's ability to engage with the support NHS support NICE experts around treatment. And for all of us, the final principle is simple. Tirzepatide is part of obesity management, not a substitute for it, which is exactly the kind of balanced, evidence based positioning A4 medicine should help clinicians communicate clearly. If this has been useful, the key takeaway is simple. NICE eligibility is based on BMI, comorbidity, and acuity adjustment, but real NHS access is phased. That distinction explains most of the confusion around Mounjaro on the NHS. I hope you found this presentation useful. If so, please subscribe to our channel on YouTube. And for further clinical resources, please visit a4medicine.co.uk. Thanks for watching. I hope it was useful.